Good morning, everybody. It's my great pleasure to welcome Professor Oliver Borens from Lausanne to this fall Harald Tscherne lecture series. I think we all know him quite well. He has been in Lausanne for 25 years now. He has a wide and long time experience for treating patients with difficult fractures and infections. As a matter of fact, he published a book that you can see right here. It is a documentation of patients that eventually required amputation for these kinds of problems. And he has had a very broad-based education. Among the experience that he has had abroad was he spent some time with Professor Helfit at the Hospital for Special Surgery in New York. And he actually was in New York when 9/11 happened. He also has been the president of the AO for the last 6 years. And at this year's conference, he gave a little bit of insight of what happened in New York. So if you are not so interested in infections, you can still ask him about his experience with 9/11 after the lecture. And so it's my special pleasure to welcome you, Oliver, and the stage is yours.
Thank you very much for this kind introduction and for the invitation. I'm very happy to be here. Actually, as I told Christoph just before, I had applied for a job here at the Unfallchirurgie 25 years ago, and after starting in Lausanne, and I was at the beginning was not very happy because I came from the Swiss German part of Switzerland. I thought that the Welsh were a little bit difficult, and after 2 months of suffering and adapting to the situation, I got a call from Trent's, from his office, and they asked me whether I could start in 1 month. And I had a huge discussion with my wife, and finally I decided to stay in Lausanne. And but I almost made it to the USZ, and finally here I am, and I can talk to you about my experience and about infection. This is a rather old sentence in most of the AO courses. You can see this sentence. Martin Algerver, one of the Holy Five, has said it many years ago. And in order to get you up to speed, I wanted to show you a case of this 20-year-old ballet dancer. You know, in Lausanne there's a famous ballet which is traveling around the entire world. And one of the ballet dancers at 21 years, she had a car accident, and these X-rays, they are not in very good quality. They were made in Argentina. And you can see these upper extremity important lesions on the femur, the forearm, and a dislocation of the elbow. So she was taken to a smaller outside hospital in Argentina. She did everything they had to do: ATLS, vascular repair, IM rods, and splinting. Then she was transferred to Buenos Aires to a private hospital where they decided to do this nailing. I think technically it looks very nice. And, well, of course, we can discuss whether upper extremity fractures should be treated with nails, but this is not the reason why we are here. And then she was transferred to Switzerland. And if you look at the X-rays, you can already ask yourself whether, especially in the forearm, there is something rotten, there is a problem. You can see here that it doesn't look that good. And well, she was transferred to Switzerland, and she came to our outpatients clinics, and here you can already see a little bit better the problem which you can have. There is some bony reaction. There's probably dead bone. We don't know exactly, but at least what we are sure of is there's a wound drainage. There is a sinus on the ulna, and with tissue cultures or with swabs. That was a couple of years ago. Today, don't do any swabs anymore because this is not going to give you good information on what's going on. But we are in this situation. We have an unstable fracture situation. There is an infection. There is a sinus. And now, of course, the question we have to ask ourselves, what shall we do in a situation like this? Is this something we can get rid of? Can we treat the infection only with antibiotics? Do we need to do some surgery? Do we just hope that it's going to go away? What would we do in such a situation? And what we decided was that in this unstable fracture situation with this bony reaction, that probably we are not going to get rid of the infection. So we took out everything. We produced these little pins which were coated with local antibiotics. So there's a cement rod with vancomycin and gentamicin. And we produced a couple of these pellets or pearls with antibiotics in it. And finally, after vancomycin treatment for 6 weeks, we took the patient back to the OR and we did this osteosynthesis with local antibiotics. And at 6 months, the patient was doing much, much better. This is an old X-ray. There's another X-ray where it has finally healed and the patient is doing well. Every now and then she sends me a picture of her still dancing. She hasn't recuperated completely the mobility of her forearm, but she is pretty happy with the result. So why am I here? I think every surgeon is afraid of infection. I think it happens. And well, one of the problems is, what is an infection? So we have decided now, we're always talking about an infection after osteosynthesis, an infection after fracture. Today, the general name we have agreed on with our expert panel, we call this now a fracture-related infection. So this is now the global name of infections in orthopedic trauma. It's fracture-related infection. But then, of course, it's always the problem, is this really an infection or is it not an infection? How can we decide it is one? What would you say? Is this an infection? Or is this an infection? In a situation like this, from time to time, I see these patients that are sent to my office and the family doctor has already put them under antibiotics. And what I always tell my colleagues when I see something like this and they have already put under antibiotics without any diagnostics is that antibiotics are not anti-inflammatory drugs. So if it's red, don't start the patient directly on antibiotics. You have to confirm the infection. I think it's not a good idea if the patient is not septic, which is rarely the case if it's a little bit red. If the patient is not septic, don't start the patient on antibiotics. Go first for diagnostics. And you're just gonna hide the infection. You're gonna make it much more difficult to find the germs. So it's really important to first do the diagnostics and then you start the antibiotics. And of course, a situation like this, yeah, it might be an infection. Here now we can start to see this little screw coming out. Now we have a proof that there's an infection. If we can see the hardware, or if I can see, as I call it, the mirror sign. You know what the mirror sign is? So the mirror sign is a famous sign in orthopedics and in trauma. It's when you can see yourself on the implant, mirroring on the implant, you can be sure that there's an infection. So this is really 100% sure sign. If you have a positive mirror sign, there is an infection. And finally, this here, if pus is oozing out, probably we are in presence of an infection. And we know that infections happen. This elbow here, there's a wonderful mirror sign here, but the others as well. These are infections and it happens to everybody. It's completely normal that if you operate, that sooner or later, you're going to see a patient coming in with an infection. I remember very well, my former boss, his first question was when he came and saw a patient, he said, who operated on that patient? Doesn't matter. Doesn't matter. Everybody is going to have an infection sooner or later. The more you operate, the more you're going to have infections. But it's normal. So of course, you have to do everything that it doesn't happen. You have to do antibiotic prophylaxis. You have to wash your hands. You have to take all the precautions not to have an infection. But sooner or later, you can do whatever you want. You can do it as perfectly as possible. It's going to happen. So it's not important who is responsible for it, but it's important what you make of it. The infectious risk is there and it's always going to be there. This is an old paper, but anyway, we know that if we do trauma surgery, we're going to have 5 to 10% which are going to have an infection. If we have open lower leg fractures, even the incidence of infection is even going up, but it's normal. So try just to realize that there's an infection and then take the good decision. Patient, 55 years old, He had 4 prior surgeries. He has a proven staph epidermidis infection, has a very bad function of his elbow, and he comes in with an image like this. What shall we do in a situation like this? What would you do? Here's a little bit a bigger X-ray where you can see a little bit better what's going on. The screws are pulling out, so it's an unstable fracture situation. The function of the elbow is bad. You can see there's lots of bony reaction. If you have a big bony reaction like this is often something you can see in low-grade infections like with staph epi or C. acnes. This is really something where you can almost say what germ you're probably going to find. And you know that probably with only antibiotic treatment, you're not going to resolve the case. Maybe you're going to have you can suppress a little bit the infection, but this is never going to be a functional elbow or a humerus which is going to go well, okay? So antibiotic treatment is probably, isolated antibiotic treatment is not going to solve the problem. So suppressive therapy is not an option here. Diagnostic biopsy, there's no sense in doing it because we know that this is staph epi. So there's just, okay, maybe one more operation, but it's not going to help us taking a better decision on what we want to do. Do we need to have more X-rays or scintigraphy, PET-CT, leukocyte, PET-CT, MRI, CT scan? No, it's not necessary because we know what's going on. So there's no need for more radiological information. Okay, maybe we can see, yeah, the CT might show us whether there's an abscess, but we know that staph epi infections are not going to produce big abscesses. Shall we go for a one-step procedure? And if so, okay, what kind of a one-step procedure can we do? Two-stage procedure or maybe something else? Well, the answer actually is very easy. Just follow the algorithm or just do it like the orthopods. The orthopods, very easy. We have, yeah, I love this. I had to take a picture of that. I think it's a very good study, Norwegian study. So anyway, we can do it like the orthopods. Yeah, just take a picture. So the orthopods, for them, it's very easy. We have an algorithm. The algorithm for the orthopedic surgeons is if you have a prosthetic joint infection, you have to decide it's an early infection, it's a late infection. Can I do a DARE, one-step exchange or two-step exchange? So let's do exactly the same as the orthopedic surgeons for their total joints. But that's not possible. You cannot apply an algorithm for infected total joints to fracture-related infections. And why can't you do that? Because it's the same bugs. So the orthopedic surgeons in infected total joints, they do not deal with other bugs. It's staph epi, staph aureus, C. acnes, exactly the same bugs. It's the same materials. So it's titanium, stainless steel. It's the same material. We have more or less the same patients. Maybe in orthopedics they are a little bit older, but we have gerontotraumatology, we have elderly patients as well. And the anatomy is more or less the same. But there is not the same goal. We have two different goals in the treatment. If we have an infected prosthesis, we need to have an eradication of the infection, ideally. And in fractures, if they are infected, we want to have a healing of the fracture. The fracture has to heal, and we do not want to have chronic osteomyelitis. And the big difference is that if we have a fracture-related infection, at the end we can remove the material. And so even if it has healed and the material was chronically infected, at the end we can take out the material, whereas if we have an infected total joint, we can't just take out the material, we have to replace it because otherwise there is not going to be any function. So we cannot treat it exactly the same way. And lots of trauma surgeons, they have tried to find an algorithm for fracture-related infection treatment. There are a tremendous amount of different ways of treating fracture-related infection. Everybody has a little bit found his own way, but there was never a real consensus until a couple of years ago, where under the lead of Metzemakers, who is now in Holland, we have created an international expert group where on one hand side, we have looked at all the papers that have been written on how to deal with infection, seeing that there was absolutely no consensus whatsoever. And in this group, we have decided as well on one definition, what is an infection, and afterwards, how can we deal with the infection? And we came up with these two levels of certainty, whether there is an infection or not, after long discussions in Davos. And we could have the first level, these are the confirmatory signs, where we are absolutely convinced that there is an infection. These are 5 signs which I'm going to show you. And then there are suggestive signs where we have to go a little bit further, where we really have to exclude and to look for an infection. So these are the diagnostic criteria where we have absolutely sure presence of an infection. Is if we have a fistula, a sinus, or a wound breakdown. So if we have contact to the bone or with the implant, or if we have the mirror sign, if we see ourselves on the implant, if we have pus oozing out of the wound, or when we open up and there is pus, we know that there's an infection. If we can find at least 2 of the same pathogen, we know that there is an infection. That's not a contamination. I think we're not going to talk now on how to do your tissue samples, but I think this is something which is very important as well on how you do it. I think probably here as well, you're using sonication as well at the end of the implants you're taking out. Another sign is a histopathological examination where we can find the microorganisms. And here, this is once again the histopathological examinations with more than 5 neutrophil polymorphs, which have been seen under the microscope. This is a last point that was confirmed on an international consensus meeting as well, and is part now of the 5 confirmatory signs. So if one of these criteria is present, only one, you can be sure that there is an infection. These are the other ones. Clinical signs, redness. Redness is not always a sign. If it's a little bit warm, not always a sign, so you can't be sure. There are studies that have been done, and even if you don't have an infection, the wound can stay, or the extremity can stay a little bit warmer than the other side for quite some time. If you have only one positive culture, it's only suggestive. You need to have more than one, because it could be only a contamination. That's the reason why you should take 3 to 5, ideally 5 tissue samples around the infection, not in the subcutis, not somewhere around, really on the plate, on the interface between the implant and the bone. This is where you're going to find the germ. If you have an elevated CRP, very suggestive, but if you have a normal CRP, there's absolutely no sign that there's not an infection. You can have a chronic infection with staph epi or C. acnes, and you can have a normal CRP, but have anyway an infection. Wound drainage, that at the beginning, after a couple of days, the wound drainage has to go down if you have operated on a patient. But if suddenly there's a new wound drainage, or suddenly you have increased wound drainage, then this is an alarm sign. There is something going on. Normally, you have to take the patient back to the OR and reoperate on the patient. And of course, if you have a patient who has had a fracture close to a joint and suddenly you have a big swollen joint and warm, you have to think about that. So these are the signs, these are the diagnostic criteria for an infection, and this is making our definition as well. Okay, now you have an infection, now you have to treat it. And here as well, there is a tremendous amount of different concepts on how to treat the infection. It's difficult to find something really helpful in the general literature, because one is doing it like this, the other one is doing like this. It's lots of eminence-based surgery, or locally, it's always done like this. If you go to South Africa, Professor Lautenbach, for years, he said the only way to do it is open wound treatment. You have to wash it out, you have to drain it out. And so there's a tremendous amount of different ways of doing it. And we saw that in this paper that has been published in Trauma Surgery as well, that it's a huge problem, because it's difficult to find something in the literature. In general, you can find in literature whatever you want. And if you have an opinion and you just want to confirm your opinion, you're going to find a paper confirming what you think, even if it's wrong. So anyway, so for us, when we looked at it, we said, so what do we want to achieve if we have an infection? What is important? Of course, we want to have fracture consolidation. I always mentioned that. We want to eradicate the infection, or at least suppress it until we have a consolidation of the fracture. Of course, we want to have a good tissue envelope, because we know that if the tissue envelope is not okay, sooner or later there's going to be a wound breakdown. It's going to start being a new problem again. We want to prevent chronic osteomyelitis. I already mentioned it. And of course, we want to have a function so that the patient can walk and move his upper and lower extremities. And for this, it's very important that we have a stable fracture situation. That was published in the 70s. It's a very old paper by one of my former bosses who said that you can only achieve fracture consolidation in a stable fracture situation. So it's very important that we have a good stability around our infected bone. So if we go on with the general considerations, there are two things at which we have to look. On one hand side, we have to look at the surgical principles. On the other side, we have to look at antibiotic regimens. So it's always a combined treatment. So we have to choose, if we talk about surgery, just to leave the implant in, so to do a DAIR procedure, débridement and irrigation, or we have to exchange the implant. And of course, we have to choose which antibiotic treatment is probably the best. If you look at the antibiotics, we need to start normally rather broad. So we have a patient that comes in, he probably has an infection. We don't start antibiotics right away. We take the patient to the OR normally, because if we need to operate on them, and then we start our antibiotics once we have taken our tissue samples. We normally go rather broad. So here in Switzerland, most of the time, if we start with augmentin, amoxicillin clavulanic, 2.2, 3 times or 4 times a day, normally we're going to cover 89% of the germs which might be a problem. Here in Zurich, if you have somebody coming back from the Balkan, probably you need to go a little bit larger. You have probably to use other antibiotics. This is something you have to decide with your specialist of hospital hygiene, who know better what are the problem germs which might come in, and even if you need to broaden the spectrum. But for the normal Swiss infected fracture patient, normally if you go with augmentin, you're going to have it, and you can leave the patient under this broad antibiotic treatment, this empiric treatment, until you have the results of the tissue cultures, and then you can adapt on what you really find. So first you start empiric, and then you're going to go adapt it to the germ which you can find. For a long time it was 2 weeks, even in US 6 weeks of IV antibiotics, and then 6 weeks of oral. Today we say normally after 1 week of oral antibiotics, normally it's enough, and you can switch after 1 week of IV antibiotics, you can switch to oral antibiotics, and this normally should do the trick and should be enough. And these targeted antibiotics, they are really helpful, and we give them until we have healed the fracture, or depending on our surgical strategy, which we are going to talk about afterwards. And the antibiotics are depending on whether we go for a retention, a removal, or an exchange of the plate, and I'm going to explain you why we are deciding like this. We have to, if we decide that we're going to keep the implant, we have to decide whether we can do an eradication treatment. That means we really want to get completely rid of the germ on the implant, or whether we want to suppress. Suppress, that means we don't want to have any general reaction on the infection. We want to have the germs that stay on the plate or the nail, but they are not going to do a systemic infection. And this is eradication, a curative approach, and here we're going to need biofilm active drugs. Biofilm active drugs, as you know, if we have germs which are normally free floating around, as soon as they get on the implant, they go onto a sessile form, which is called biofilm. It's a biofilm form. They are in some kind of of a glue, kind of a slime in which they are protected from our antibiotics. And if this slime is mature enough, we are not going to be able to get rid of these bacteria. And the only two drugs which we know which are helpful to get rid of this slime, of this biofilm in an early phase, is rifampin, which we are using in infections with staphylococci, with the epidermidis or oris, and in situations where we have C. acnes infections. So it's gram-positive infections, but only staphs and C. acnes. There's no sense in giving rifampin for a streptococcal infection. We tried to do that for a certain time, but finally showed that there is no help. If we have a gram-negative infection, we can use quinolones. That's most of the time it's ciprofloxacin. So ciprofloxacin is an antibiotic which should not be used in staphylococcal infection, but in gram-negative infections. For a long time in US as well, in the textbooks, if you had a redness around external fixator, you were giving ciprofloxacin because it was a Staph aureus infection. Normally don't. This is something which is not adapted today anymore. And of course, if we have a difficult to treat pathogen, which means that if we have a germ which is resistant to rifampin or to quinolones, at that time we know that we are not going to be able to eradicate the infection. We can only do suppressive therapy, but for this we don't need antibiofilm drugs, because the problem of the antibiofilm drugs, mainly rifampin, is an antibiotic which is not very well supported. So this is a little bit complicated, and that's the reason why I think that today in a bigger hospital, but even in a smaller hospital, if you are dealing with infections, you should always do that with an ID specialist who is specialized in implant-related infections. Because from time to time, if you talk to an ID specialist who is not dealing with fracture-related infections, for him a Staph aureus in the lung is the same as on a bone and on a plate and in a prosthesis, and then they just say, well, just take out the stuff. And then they say, yeah, but it's not possible. It's a little bit more complicated than that. So it's really, we need to have ID specialists which are really specialized in our problem. So we've talked about the antibiotics. Now we're getting back to surgery. We have a fracture-related infection. We have done a wonderful osteosynthesis. And sooner or later, the patient comes in and we know that there's an infection. The signs are positive. And our first question when we have to decide now what are we going to do with the patient, we have to ask ourselves, is the fracture healed? Because if the fracture is healed and there's an infected plate on it, it's very easy. If the answer is yes, we remove the implant. We take the implant out and we do an osteomyelitis treatment. So normally for 6 weeks, antibiotic treatment, and normally the problem is solved. It's getting more interesting if the fracture isn't healed. So now we have a non-healed fracture. And if it's not healed, we have to ask ourselves, well, can I keep the implant or can I not keep the implant? And in which situation, and this is, I think, an important slide which is coming up now, is in which situations can I not keep the implant? This is if I have an unstable osteosynthetic construct. That means the osteosynthesis is just not good enough. It's probably not going to work. It's not going to heal out. It's too unstable. As I mentioned, Villanegra and Rittmann in the 70s showed we need to have a stable construct. So if we know from the beginning on that our osteosynthesis is not sound, that it's not holding, there's no sense in just trying to keep the implant. We have to get it out. If sufficient debridement is not possible, so a sufficient debridement is normally possible if you have a plate, but even with a plate, if it's easy to change, I normally change the plate, because below the plate often there is biofilm and the cleaning out is not that easy. But if we have an infected nail, normally we are never going to be able to really sterilize this nail, even with good antibiotics, because the load of germs is just too important. So if we have a situation like this nail, which is definitely not a perfect osteosynthesis because it's definitely not very stable, but especially we cannot get rid of the infection only with antibiotics. So if we have a nail, we have to clean out the medullary cavity because we don't want to have appendicitis. So we have to change the nail. If we have a compromised soft tissue envelope, this is going to be difficult. Normally we have to change the implant. If the physiology of the host is showing that he's just a B host and it's not going to heal because soft tissues and general conditions are bad. And if it has been infected for too long time, so we're not going to be able to suppress. In these situations, normally we're going to say that the implant retention is not possible. So if it's not possible, and I mentioned again what are the different points, or different questions we have to ask ourselves. If we say no, it's not possible, then we take the patient back to the OR, we exchange the implant, and then we go for eradication therapy because the implant is clean. There is no biofilm on the implant. Normally, the biofilm is not somewhere in the muscle or in the soft tissues. It's on the implant. If we change the implant, if we clean the bone, normally we can eradicate the infection, and we do need antibiotics which are going to help fight the biofilm and eradicate. If our answer to the implant retention possible, yes, we have to look at whether it's a difficult to treat organism or not. If it's a difficult to treat organism, so it's a no answer, we can use antibiofilm treatment. It hasn't lasted too long, so we can still get for eradication. So we need eradication antibiotics after the washout, after cleaning. And if the answer is yes, so it's a difficult to treat, we can't use any antibiofilm treatment, then we're going to suppress the infection with antibiotics, in this time not antibiofilm antibiotics, until we have a healing of the fracture, and then we can take out the implant. So in our case, which I showed at the beginning, finally we decided to go for something else. We did a free fibula and external fixator, and then after 5 months it healed out. So for me, what is important, or the take-home messages, and of course one could continue to discuss these infections for hours and hours, there are a couple of important points. So the first thing is, consider the impossible. So even if you have done a wonderful operation, it's possible that it's infected. Okay? There's no sense in saying I have done now 200 osteosynthesis of the ankle. I have never had the slightest complication. It's not possible. It's always possible. It happens to everybody. If you are not sure, ask a colleague to take a look at the wound and let somebody other decide. If he is a good friend, he's going to be honest with you and he's going to tell you, yes, I think it's infected. If he's not a good friend, he's going to say, no, I don't think it's infected. So it's always a little bit tricky, but I'm sure that sooner or later, you're going to find the good person to really help you take your decision. And as soon as you think, oh, it might be infected, you must rule the infection actively out. Because if you think there is one, so always this little angel and little devil saying, it's infected, no, it's not infected, it's infected. No, so just rule it out. So make the diagnosis, go for the diagnosis. I have shown you now what are the signs of a sure infection and a most likely infection. And of course, there are different diagnostic tools as well to do it. Follow easy treatment concept. I think this is a concept which works, which has been established by an expert group. If you need, ask for help. Don't hesitate to ask somebody who is going to help you. Even it can be a senior, it can be a junior, but ask their opinion, what they think. From time to time, it's easier to take this tough decision to take the patient back. It's always teamwork. It's teamwork between orthopedic surgeons and ID specialists, microbiologists, nutritionists. So we always have to combine our surgery with antibiotics, and more and more now we have orthoplastic surgeons, plastic surgeons, which are going to help us really debride and be aggressive with the soft tissue treatment, because as long as the soft tissues are not okay, your bone and the plate below is not going to be okay. So soft tissues, for me, the older I get, the more I think that the only thing which is really important in orthopedic trauma is the soft tissues and not the bone, because if the soft tissues are not okay, the bone is not going to be okay. And so that was a rather quick overview. This is a book we wrote with the Swiss orthopedic expert group together with the infectiologist, the Infektion des Bewegungsapparates. You can order it for free as a PDF in English at the heroesmedical.com site. So you can download it on your iPhone or iPad or whatever, and you can look at it. It's normally rather up to date. And then it's for those who want to read in French or in Spanish, Chinese, Russian. It's been translated in numerous different languages. And as Christmas is getting closer, there's an AO book as well that we wrote on the principles of orthopedic infection management. I don't get a dime if you buy it or not. So it's not me getting rich with it. I got 5 books for the entire work, but I think it's a very good book for your library. You can ask your boss to buy it for the entire team for Christmas. With this, thank you very much for your attention, and I'm happy to answer all the questions you might have. Thank you very much.
Well, thank you very much. That was a fantastic overview. It is truly a complex topic. Are there any questions offhand from the group?
Nice talk you gave to us about the soft tissues. I agree with you. The soft tissues are the mainstream for, let us say, the healing of the infections. So it's nice that you have that addressed it very well. The second question is about how about the rifampicin? I'm not so in favor on it, because what I've seen here is if you use it, let us say, you're getting more and more quicker resistances. The only way where I would like to use the rifampicin is in early infection of prothesis. But the other way, let us say, for osteosynthesis, I'm not so sure if, let us say, this is the right adjunct. So what do you feel?
So it's an absolutely valid question. For me, at the beginning, I was not very much in favor of rifampicin for FRIs as well. But I think it depends very much on the goal you want to achieve. And it depends on the soft tissue situation and at the timing when you start with the rifampicin. So as long as you have an oozing wound and as long as the wound issue is not resolved, you should not use rifampicin. You have to have a dry wound. So I 100% agree. You should not use it at the beginning when you have a bad wound situation, when you think that probably you're going to have to go back in 2 or 3 days. Don't use the rifampicin. Start the rifampicin once the wound situation is stabilized. And there we have been able to show that then the results are going to be better. But it depends, once again, it depends on whether you want to do a hardware removal rather quickly, whether you want to be eradicative, or whether you want to be suppressive. But if you want to have eradication of the infection, the best chances of having eradication, if you have rifampicin susceptible germs, is to use rifampicin. And normally it has not been shown that we have a much higher increase of rifampicin resistance if we use it correctly. And of course, the other problem is that there are lots of side effects. So I think you have to judge it wisely, but I would not say that rifampicin has not a place in fracture-related infections. You really have to choose wisely. But and once again, there are lots of patients which do not, where you can't use it, and that's the reason why I tried to show you really have to decide whether you want to have eradication or not, because there are situations where you do not want to go back and do the hardware removal because it's too complicated, too dangerous, and you would like to go for eradication.
We have started a cooperation with our ID group about 2, maybe 3 years ago, and it's really working very well. And I was wondering, what kind of patients do you usually present to them? Is it if you have a red and swollen ankle, do you discuss this kind of patient, or do you wait until the infection is proven, or when do you start involving them?
So we have a septic ward at my hospital. So I used to have 40 beds, now I have 25 beds with orthopedic infections, whether it's total joints or FRIs, diabetic feet, and so on. And there we see all these patients, they are seen together with one ID specialist specialized in hardware infection. So I have a fixed infectiologist, used to be Andre Trampels at the beginning before he went to Charité. And so we saw all these patients always together. And it's exactly the same when we have outpatients clinics. Normally, if there's the slightest discussion, we're going to call our ID specialist. But of course, if it's just a little bit red, we are not directly going to call them in. But if we decide, okay, do we need now to start the patient under antibiotics, we're going to discuss with them. But until we go on with the diagnostics, we don't really need them, because we have lots of experience now on what exams do we want before we start discussing which antibiotics. But we often have patients which are on the wards in internal medicine or somewhere else. They often, first they call the ID specialists, and then they always call us, so we go and see these patients together. So it's really on case per case, but normally the rule is as soon as there is the slightest doubt, we see them as a team. Yes.
Thank you for the nice talk. You told us how important the stability is in infection treatment. Is relative stability, is that enough for the infection control, or do you change in shaft fractures relative stability to absolute stability?
No, I don't think that you need to go for absolute stability. I think you're not, if you have a nail, you exchange the nail, you're going to know that there is still a relative stability, but that's not such a problem. You just need the fragments not to move too much, because every time it moves, all the little vessels which are going to try and grow and start to callus formation, they're going to be disrupted again, and then you're going to have a change in the pH, and it's just not going to heal out. But if you have relative stability, that's okay. You just need some kind of stability.
Yeah, thank you for the nice talk. If you set the indication for rifampicin, you combine it with a second antibiotics, because as I understand, it's only for the breakthrough of the coverage, and then you use the specialized antibiotics for the antigen, right?
Yes, absolutely. So I'm sorry, I wasn't clear enough. So rifampicin is never a monotherapy. It's always a combined therapy in order to protect your rifampicin. I'm sorry, I didn't mention that, but you're absolutely right. It's always combined antibiotic treatment. Absolutely.
I have a practice question. In your opinion, what's the best disinfection solution for cleaning out the wounds intraoperatively? So what do you use?
So once again, there are lots of discussions. There are Octisep, there are Lavazep. Everybody has his own mixture of using it. For a long time, we thought that even peroxide was a perfect way of cleaning out. So it was like lots of foam forming and all that, but it's very cytotoxic. So what we know is the washing out. The most important thing of the washing out is what I always call the dilution is the solution to pollution. It's the amount of liquid you're using. And it's the mechanical reaction, the mechanical washout which you need to do. You can even scrub a little bit the plate, and then you can put in some substance. Chlorhexidine 006 is something which has been proven. Then there are other groups. In open fractures, they use Castilian soap to wash it out. For us, we normally use mainly normal saline. If it's very dirty, maybe a little bit of betadine, and then we wash it again out with saline. We don't use peroxide anymore because it's just too cytotoxic. But then there are lots of different liquids which are on the market. For me, the most important thing is really the amount of washout you're doing and the quality of the debridement.
The patient in the first case you presented was a ballet dancer. Based on your experience, which role does malnutrition or a reduced bone density play in terms of FRIs?
You mean the quality of the bone and the impact of infection?
Yeah, and malnutrition generally.
I don't know whether the quality of bone is so important, because I don't think that bad osteoporotic bone, if this is your question, is less well irrigated. It's still irrigated. So the antibiotics still get there. So I don't think that there's a... For me, if I have an infection of a total joint in a 90-year-old patient, or in a 40-year-old patient, the treatment is exactly the same and the results for the same germ, for the same operation are similar. So I don't think that elderly patients do react less good to an infection or to antibiotics, except if they have vascular problems and a vascular issue where the antibiotics are not going down to the foot or to the ankle, and that's a problem. You can say the main problem, I think, in elderly patients, why they have maybe more infections, is because of soft tissue, of bad soft tissues. The irrigation of the soft tissues is less good, but I don't think it's a bone problem. But it's a good question. I never asked myself this question, but that's what I would answer.
Normal implant removal. Do you do antibiotic prophylactic applications? Question number one. And how important is the surgical hand disinfection? Do you use the 2-minute clock prior to going into the OR?
Yeah, very good question. So I always make a joke that the higher you are in the hierarchy, the quicker your hands are disinfected.
And that's not true.
Exactly. I always make the joke because I think everybody sees that the higher the staff member, the quicker, and he goes out, he takes a look, okay, I'm going to wash in, and then after 10 seconds he's there, okay, puts on the glove. No, I think it's 2 minutes is mandatory. I have to admit that from time to time it's not exactly 2 minutes, but ideally we know that you really have to follow these hand washing rules. They are extremely important. It has been published by the WHO, and this is really standard, and that's really, really important.
And so we have a timer for that.
We don't have a timer, but normally it's written that we have to do 2 minutes. But of course, it's a mentality problem as well. I think if you work in a hospital where people are going to follow the time where they're going to turn it, okay, I think it's a good thing to have. But yes, we don't have it, but I tell people you really need to do that. For the first question, normally for a normal removal of hardware, you don't need antibiotic prophylaxis. And for instance, you don't need antibiotic prophylaxis if you do a standard arthroscopy, if you put in a pin, if you do an X-fix, you don't really need antibiotic prophylaxis. But for removal, normally no. Then, of course, if you do a very complex removal of hardware, which is going to take a long time, it's normally not indicated, but most of the people are doing it because it's just a long-term operation. But you can argue that normally if you give you antiprophylactic treatment, you want to protect your implant. It's not to protect the bone or to protect the muscles or the soft tissues. You want to protect your implant. If you're taking the implant out, so you don't really need any antibiotics. What I think is maybe more interesting, more important is that if you go for an operation and an infection and you're planning on changing the implant or putting a new implant in, I would always give my prophylactic antibiotics before I started the operation. This has been shown in a couple of papers from all over the world, that the rule that you should withhold the antibiotics in order to take tissue samples, and then you take out your plate and you put in the new plate, and it has been taking the tissue samples and putting in the new plate has been 2 minutes. This is dangerous because the new plate is not protected. And then you might lose this famous race for the surface described by Christina. So what we always do is, if we know that we're going to change the implant, we are going to give antibiotic prophylaxis or the augmentin, as I mentioned before. And we know that this is not going to have an impact on our tissue samples, because with one single dose given 45 minutes before, you're not going to kill the bugs which are on the implant, which are around the implant. Your quality of your biopsy is not going to be less. The sonication is going to work, but you're going to protect the new implant. And I think this is very important. 20 years ago, 15 years ago, all of us, we learned if you have a suspicion, you have to take it out. Then you have to withhold the antibiotics. You have to take it out, and then you have to put on the plate, and then you have to give the antibiotics 5 minutes before you open up your tourniquet. And this is really the safest way, or the surest way of having an infection of the new implant. So give the antibiotics before. if you change the implant.
Any further questions? I think we can all be very grateful that to have had you here. I think one important aspect is that you have been on this group that determined the definition of an infection. So I think if we want to change and improve something in our department, we will probably use these criteria and put it somewhere in our little booklets and make sure that we use them, because it's really helpful. I think before 2019 there was like a foggy situation. There was level 4 evidence of guys that knew how to do it, but now finally there's clear-cut criteria, and it's like stage 1 and whatever. So that's really helpful. Thank you again for being with us today, and I know that your desk is very full, but we thought that maybe something else can be added, and so we have this little thing for you for the desk. And thank you again for coming.
Thank you very much. Thank you. Thank you for your attention.